panelists will be with us virtually in a few minutes. There is an interesting debate among the people of this country about which powerful special interest has the most clout on Capitol Hill. Some people think it may be Wall Street, and some people may think it's the military-industrial complex, and some people think it's the fossil fuel industry. I myself may be wrong, but I would give the nod to the pharmaceutical industry, an industry which charges the American people by far the highest prices in the world for prescription drugs, and has managed to create a situation where they can raise their prices to any level they want any day of the week. So today people are walking into a drugstore, walking into a pharmacy, pharmacist is telling them, sorry, price of your medicine has substantially gone up. That's what the drug companies have done. Drug companies are an industry which year after year make huge profits, and they pay their CEOs incredibly large compensation packages. It is an industry which is significantly responsible for the fact that in the United States we pay the highest prices in the world for health care, almost double what any other country pays. It is an industry which has an incredibly opaque pricing system, which pays one branch of government, which charges one branch of government a very different price than it charges another for the same drug. Same exact drug, Medicare will pay a price, Medicaid will pay a price, Veterans Administration will pay a price, community health centers will pay a different price, all for the same exact drug. And that's true for hospitals, for nursing homes, and for individuals. Very hard to know what they are charging anybody else. This is an industry that has paid $32 billion in fines for a variety of illegal actions over the last 20 years, including price fixing, overcharging the federal, state, and local governments for their products, bribery, collusion, fraud, and deception. And yet this is an industry which keeps going on its merry way, virtually untouchable year after year after year. Now, how did they get away with that? And it is not hard to understand. During the last 23 years, the drug companies have spent $7.6 billion on lobbyists, $7.6 billion over the last 23 years, including the former leadership of the Democratic and Republican parties. They have more than 1,500 lobbyists here in Washington. There are 435 members of the House and Senate. They have 1,500 lobbyists here in Washington, as well as lobbyists in virtually every state capital in this country. Since 1990, they have spent nearly $730 million on campaign contributions, which have gone to many, many hundreds of members of Congress in both political parties. Let's be clear, the pharmaceutical industry is not particularly sympathetic to the Democratic Party or the Republican Party. They try to buy both parties. In fact, I think it's fair to say that it is not Congress which regulates the drug companies, but the drug companies which regulate Congress. And that has got to change. Congress finally, after years and years and years of talk, finally has got to summon up the courage to take on the drug companies and lower prescription drug prices in America. That is what the American people want, and that is what we need to do. Last year, 1 out of 5 Americans cannot afford to buy the medicine prescribed by their doctor. How crazy is that? Walking into a doctor's office, getting a diagnosis, getting a prescription drug, but you can't afford to fill it. Meanwhile, while Americans are dying or getting sicker than they should because they cannot afford the medications they need, 9 large drug companies made over $58 billion in profits last year. $58 billion in profits, 9 companies, while just 6 pharmaceutical industry CEOs made $564 million in total compensation over the past 3 years. Not too shabby. Every day in my office, and I'm sure every congressional office, we hear stories from Americans unable to afford the prescription drugs they need. Today, we will hear from Ms. Elia Spates from Derby, Vermont, who will tell us how the outrageously high price of insulin in America has impacted her life. And of course, she is not alone. In 2018, 1 out of every 4 Americans with type 1 diabetes were forced to ration insulin because they could not afford it. You believe that? 1 out of 4 Americans with diabetes forced to ration insulin. Let's be clear, insulin is not a new drug. It was invented nearly 100 years ago by Canadian scientists who sold the patent rights for insulin for just $3 because they believed it should be accessible to everyone who needed it. And yet, over the past decade, the price of insulin has gone up by over 300%. Yet, 50 miles from my home in Vermont, you can purchase insulin in Canada at about 1/10 the price that we pay in this country. And let's be clear, prescription drug prices in Canada are also high compared to other countries around the world. According to a recent study by RAND, a standard unit of insulin costs $98 in the United States, $12 in Canada, $11 in Germany, $9 in France, $7.52 in the UK, and $6.94 in Australia. And it's not just insulin. A 1-month prescription of Entocort to treat Crohn's disease costs $830 in the US, $81 in Canada. 1 asthma inhaler, Flovin Discet, costs $242 in the US, $27 in Canada. 2 EpiPens cost $686 in the United States, $278 in Canada, on and on and on it goes. Same medications manufactured by the same companies in the same factories, all available in countries around the world at a far, far lower price than here in the United States. In my view, we can no longer tolerate a system that allows the former CEO of Gilead to become a billionaire by charging $1,000 for a hepatitis C drug called Sovaldi that costs just $1 to manufacture and can be purchased in India for $4. Can no longer tolerate a system that allows the chairman of Mylan, Robert Corey, to receive a $164 million compensation package in 2016 after his company jacked up the price of EpiPen by 550% over a 9-year period. All over this country, the American people are asking a simple question. How many people need to die? How many people need to get unnecessarily sicker before Congress is prepared to take on the greed of the pharmaceutical industry? The American people are demanding that Congress listen to their concerns and not cower before the power of the pharmaceutical companies. In order to begin to address this issue, I have introduced 3 bills with many of my colleagues in the Senate and the House that would substantially reduce prescription drug prices in this country and also save the federal government significant sums of money. The first bill is the Prescription Drug Price Relief Act, which would cut prescription drug prices in half by pegging the price of medicine in the United States to the median price in 5 major countries: Canada, the United Kingdom, France, Germany, and Japan. Second bill is the Medicare Drug Price Negotiation Act, which would direct the Secretary of Health and Human Services to negotiate lower prices for prescription drugs on the Medicare Part D. Every other major country on earth, in one form or another, negotiates drug prices, and the time is long overdue for Medicare to do that as well. According to a recent study, if this bill became law, the United States government could save more than $345 billion over the next decade. Third bill, the Affordable and Safe Prescription Drug Importation Act, would allow patients, pharmacists, and wholesalers to legally purchase safe, low-cost medicine from Canada and other major countries. We import all kinds of stuff, food, everything else. No reason why we cannot safely re-import prescription drugs. So with that, bottom line is, we've been talking about this issue for decades. It is time to act. Senator Collins.
Thank you, Mr. Chairman, for holding our very first subcommittee hearing on an issue where I hope that Democrats and Republicans can find common ground, and that is improving the affordability of prescription drugs. When a doctor prescribes a needed medication An insurmountable barrier to taking it should not be its cost. More than half of Americans, an overwhelming majority of our seniors, take at least one prescription drug each month. For many, access to these medicines not only is critical to their well-being, but also can literally be a matter of life or death. During my recent tenure as chairman of the Senate Aging Committee, one of my top priorities was to uncover the reasons for spikes in pharmaceutical drug prices and to help make medicines more affordable for more Americans. I led a bipartisan investigation with then Senator Claire McCaskill of Missouri on sudden price spikes of off-patent drugs and the manipulation of the market by people like the infamous Martin Shkreli. I also worked with Senator Bob Casey to investigate various entities in the opaque market for pricing of prescription drugs, such as pharmacy benefit managers. Our committee also held hearings on the price of insulin and drugs to treat rheumatoid arthritis, listening closely to patients and other witnesses. The answers that the Aging Committee received from its inquiries, investigations, and hearings resulted in several bills being signed into law. For example, the Making Pharmaceutical Markets More Competitive Act provides a more transparent and open application process for generics. It expedites the timeline for FDA to review and approve applications. Since enactment of this law, not only are we seeing more applications, but approvals are up considerably, with 28 priority generics and 35 competitive generic therapies approved in fiscal year 2020 alone. The Patient Right to Know Drug Prices Act and the Know the Lowest Price Act banned pharmacy gag clauses. They prohibited pharmacists from telling their customers if their prescription would cost less if they actually paid for it out of pocket rather than using their insurance plans. This legislation also required the disclosure of settlements reached between biologic and biosimilar developers to the Federal Trade Commission. This has been required of generic drug developers since 2003. At the end of 2019, Congress passed legislation that will improve and streamline the FDA approval process for new forms of insulin, which should usher in more competition into a category that has seen huge and unwarranted price increases. And at an Aging Committee hearing on the cost of insulin in 2018, a father from New Gloucester, Maine, testified that insulin for his 13-year-old son with type 1 had tripled in price, forcing him to purchase from Canada at a lower cost, very similar to what the chairman has described. The cost of insulin is among the most prominent examples, and I'm grateful that a constituent of the chairman is here today to share her own story. As co-chairs of the Senate Diabetes Caucus, which I founded in 1998, Senator Jean Shaheen and I introduced legislation in the last Congress to create a new pricing model for insulin, which, as the chairman pointed out, was first isolated a century ago in Canada, and yet has soared in price in recent years. Recently, we have seen some nascent steps on insulin affordability. More than 1,700 Part D and Medicare Advantage plans have agreed to cap monthly copays for insulin at $35 this year. Additionally, manufacturers are adding more affordable options, such as Eli Lilly's $35 copay program, which has been available during the pandemic. These are good first steps, but I hope we can do much more. Another focus area is biosimilar competition. Later this spring, along with my colleague, Senator Tim Kaine, I will reintroduce the Biologic Patent Transparency Act to prevent drug manufacturers from gaming the patent system. Time is money when it comes to abusing the patent system to thwart competition. There are reports that AbbVie, the manufacturer of Humira, filed 247 patent applications for this drug and won patents that could have protected the medicine for up to 39 years from any competition from a biosimilar. In fact, the price of Humira in the United States increased by an additional 6.2% in January of 2019 to offset price reductions from biosimilar competition overseas. Mr. Chairman, in the last Congress, 3 committees, the Health Committee, the Finance Committee, and the Judiciary Committee, all advanced bipartisan bills to reform our broken drug pricing system. I was a co-sponsor of the Grassley-Wyden bill in the last Congress, as were several members of this subcommittee. HHS Secretary Becerra and I spoke about drug prices at length during his nomination process. Let's bring this bill to the Senate floor as separate legislation so that we can have full and open debate and amendment to come up with the best solutions. We want new medicines to reach consumers and for pharmaceutical companies that invest in the research and take the risks necessary to develop these drugs to see a fair return on their investment. But we must do more to ensure that these essential medicines are more affordable and their prices transparent. I hope that today's hearing will help us craft policies to strike that balance. Thank you, Mr. Chairman.
Thank you, Senator Collins. We have an outstanding group of panelists, and let me begin by welcoming our first panelist, Dr. Aaron Kesselheim, who is a professor of medicine at Harvard Medical School and a faculty member in the Division of Pharmacoepidemiology and Pharmacoeconomics in the Department of Medicine at Brigham and Women's Hospital. Dr. Kesselheim created and leads the program on regulation, therapeutics, and law, an interdisciplinary research program focusing on prescription drugs and medical devices, patient health outcomes and regulatory practices, and the law. He has authored over 450 publications in peer-reviewed medical and health policy literature. Dr. Kesselheim, thanks very much for being with us.
Thank you, Chairman Sanders, Ranking Member Collins, and members of the committee. We're here today because the U.S. spends far more on drugs per capita than any other industrialized nation, over $1,200 in 2018, while the OECD average was less than $600. High U.S. prices are primarily driven by spending on brand-name drugs, most of which have been on the market for many years, during which time they're subject to astonishing price increases. We compare drugs that accounted for the highest Medicare Part B spending with Japan, Germany, Switzerland, and the UK, and found prices 46 to 60% lower in those places. How is this possible? I want to focus on 3 reasons and their solutions. First, the U.S. allows drug makers to set prices after FDA approval at any level they want, and then requires Medicare and Medicaid to pay no matter what the drug's clinical utility. Second, we allow manufacturers to raise those prices each year beyond inflation. And third, manufacturers extend their patent-protected market exclusivity by building a thicket of dozens or even hundreds of patents to delay generic entry. Other industrialized nations, even some states and payers in the U.S., have strategies that address these issues. The first step is to address excessive drug prices would be to evaluate and negotiate. The Defense Department isn't forced to buy every new weapon at the price Raytheon conceives of. It determines the product's usefulness and negotiates. The approach in other countries begins after regulatory approval with a process known as health technology assessment, in which independent organizations help determine a fair price based on how well the new drug performs against other available treatments. Only if a drug provides more benefit to patients should it cost more than other options. The U.S. needs to establish a publicly funded body that would determine a price for a drug based on its clinical benefits. In Germany, drug evaluation and negotiation occurred during a drug's first year when a nonprofit, non-governmental research organization assesses its therapeutic benefits. In a review of outcomes in that market, we found that no drugs providing important benefit left the German market, while cancer drug prices substantially declined and were more closely aligned with clinical benefit. States like New York and Massachusetts have now initiated such a review process for their Medicaid programs. My second major recommendation is to limit drug price increases. In the U.S., Gleevec was introduced in 2001 for a list price of $26,000 a year and increased to more than $120,000 by 2016. Many brand name drugs provide rebates to commercial payers and Medicare Part D plans, but those only offset some of these price increases. By contrast, in other countries, agreements between the government or payers and manufacturers restrict price increases. We found that spending per unit for the cancer drug lenalidomide in the U.S. increased from 2010 to 2018 from about $400 a unit to nearly $700 a unit, while during that same period of time, the drug in France decreased from $239 a unit to $202 a unit. One model would be to extend the drug price inflation rebate penalty currently in place for Medicaid. Bills were introduced in the prior Congress with bipartisan support for this plan, as Ranking Member Collins mentioned. A final component would be to arrange for more efficient transition to a competitive market. Generic or biosimilar entry is often delayed in the U.S. because of patent thickets covering trivial attributes of the drug. Here again, lessons on how to improve experience in the U.S. can come from other countries. Results from foreign patent offices suggest that the U.S. Patent Office could reduce the number of wrongly issued patents by allocating greater resources to ensure patent quality. In addition, we could leverage the Patent Trial Appeals Board set up by the 2001 America Invents Act to weed out invalid patents before they get caught up in litigation by reviewing patents listed by the FDA. So there is my prescription, informed by successful policy initiatives in other countries and U.S. states. Independent therapeutic evaluation leading to price negotiation, limits on price increases, and efficient generic entry at the end of market exclusivity. The industry may contend that any drug pricing reform will reduce innovation, but meaningful innovation need not decline. Large pharmaceutical manufacturers invest only about 10 to 20% of their revenues in R&D. To ensure new therapeutic insights, we must augment support of the NIH, since transformative drug innovation often emerges from publicly funded research and development, as it recently did for COVID-19 treatments and vaccines. In reality, these policies are likely to actually improve meaningful innovation. In the last decade, only 1/3 of new drugs in the U.S. were rated by one of these international independent organizations as having even moderate therapeutic benefit. If drug prices more adequately reflected the clinical benefits that they offer to patients, this would incentivize more meaningful pharmaceutical innovation, and there would be less investment in making trivial changes to existing products and more investment in meeting unmet medical needs. Generous rewards would still be provided for creating important new medicines. Most importantly, with the changes I've proposed, policymakers can rest assured that more patients will be able to access these vital products at an affordable price. Thank you very much.
Dr. Kesselheim, thank you very, very much. Our next witness is Dr. Nav Persaud, who is the Canada Research Chair in Health Justice and Associate Professor at the University of Toronto. He's a staff physician and scientist at St. Michael's Hospital and Unity Health Toronto, where he provides care to patients and leads studies as part of the MAP Center for Urban Health Solutions. Dr. Persaud, thanks so much for being with us.
Thank you and good morning. In Canada, per capita drug spending is $879 versus over $1,200 in the United States. Per capita spending is about 40% higher in the United States, largely because of the regulation of patented drug prices by the Canadian Patented Medicines Prices Review Board. Posted prices for patented medicines are approximately 3 times lower in Canada. The Patented Medicines Prices Review Board is slated in July to drop the United States from its list of comparator countries used to set price ceilings because prices are shockingly high in the United States compared with other high-income countries, including the United Kingdom. The marketing of a raft of patented medicines during the 1990s boosted per capita spending disproportionately in the United States. The large rise in drug spending during the 1990s was partially due to patented opioid products such as OxyContin that was illegally marketed by Purdue Pharma on the lie that these medicines were safer and less expensive alternatives. Pharmaceutical companies continue to profit from the opioid crisis that killed approximately 80,000 Americans in the 12-month period ending in May of 2020. Pressure and lobbying by pharmaceutical companies have undermined reforms in both Canada and the United States. Multiple government reports over decades have recommended including medicines in Canada's publicly funded single-payer system to improve fair access and to save billions each year. But this has not happened, so we continue to pay high prices that comparable countries such as Norway and Australia, and inequities persist in Canada. America is a superpower that has not shown its strength in standing up to pharmaceutical companies that rip off Americans, as proven by the price differences for patented medicines across our border. My colleagues and I have conducted a randomized control trial of distributing essential medicines, as per international guidance from the World Health Organization, to people who report not being able to afford them. We found improvements in the control of blood pressure and diabetes, fewer missed medical appointments, and total healthcare savings that average more than $1,000 per patient per year. The biggest benefit was in the ability to make ends meet or afford basic necessities such as rent and food. Only 29% in the usual access or control group could make ends meet, but 86% of those who did not have to pay out of pocket for medicines could afford necessities. A farmer in our study, for example, was better able to grow food when he had his asthma puffers. Could publicly funding a list of essential medicines work in the United States? It already is working at the United States Veterans Administration. Since its creation in 1997, the VA's national formulary has led to improvements in care, and its negotiating power has led to impressive price reductions. The VA's approach of creating a rational list of medicines and then using proven methods to negotiate prices accords with international guidance. It's a model that could be adapted to an even larger scale in the United States. There are three key elements of government action to reduce drug spending while promoting access and equitable care. 1. Punish abusive pricing of patented medicines by creating a new bureau. Create a new bureau to set price ceilings for patented medicines. Give that bureau the resources and teeth to keep prices low, and empower that bureau to issue compulsory licenses when companies price patented medicines unreasonably. The new bureau should be able to cut annual drug spending by at least $100 billion. 2. Use negotiating power in open tendering processes to secure low prices on a defined set of essential medicines as per international guidance. Negotiating power can help to ensure equitable access to needed medicines, including off-patent or generic medicines. 3. Use existing legislation and additional political will to discipline the companies currently bloated by high medicine prices that illegally market products. There's a need for urgent action. Americans are getting ripped off by more than $100 billion per year, and this money in the wrong hands is used to illegally market medicines that kill Americans. Thank you.
Thank you very much, Dr. Persaud. Next, we have Ms. Elia Spates, who lives in Derby, Vermont, who was diagnosed with type 1 diabetes when she was 18. Her struggles to manage the disease and the associated costs have transformed her into an advocate for lower drug prices and better health care. Ms. Spates, thanks so much for being with us.
Thank you. My name is Elia Spates. I was diagnosed with type 1 diabetes 23 years ago, and quickly my parents and I got a crash course in the world of insurance and the serious expense of diabetes. The insulin that I take now costs over $2,000 out of pocket per month. The rise that I have seen in this price in the last 23 years is astronomical. In fact, from 2002 to 2013, the cost of insulin tripled. When you pay over $800 per month for an individual in insurance premiums and pay an additional $2,000 per month until your deductible is met, your family starts to feel a financial pinch. The only way you see to cut back on the spending is to cut back on the insulin. Before you know it, your diabetes is out of control, your blood sugars swing dramatically, seizures happen, and you are even found unresponsive. It's time to treat the disease seriously. The financial side of diabetes is as much or more a burden as the disease itself. I am certainly not the only diabetic out there who has rationed insulin to help fend off a steadily accumulating debt. In fact, 45% of diabetics at one time or another will compromise their care to cut their costs. However, what is happening is that those who are not as fortunate as I land themselves in the hospital in traumatic circumstances and may even die. 7.5 million Americans rely on insulin. 1.5 million of those are type 1 diabetics. A few years ago, my doctor suggested going to Canada. I live just 4 miles from the Canadian border, so this was logical. Until you give it just 1 ounce of thought. I pay over $10,000 a year in insurance premiums so that I can go buy my insulin in another country and it doesn't count toward my deductible. It is completely asinine to think that I would go to another country to buy inexpensive medication and yet pay for a healthcare plan in my own country that is only compounding my diabetic problems. Twice I have arrived at the pharmacy to pick up medication that had been prescribed by my doctor, and both times I was told that my insurance company was no longer going to cover that brand without prior authorization. However, they were happy to cover another suggested brand that was biosimilar but not bioequivalent. With this medication, it had taken me over a year to get it approved by the insurance company, and I was finally having success using it, and now it was being disallowed. It is infuriating to know that in one fell swoop, your perfect combination can be undone by the companies that produce the medication and the pharmacy benefits managers who market it to the insurance companies who now give it preferred status on their healthcare formularies. Just 6 months later, an insulin I had been on for over 4 years became no longer an option. Once again, it needed a prior authorization, but there was a similar medication that I could have. Now, had this been the difference in brand name to generic,
Prices have not fallen because there's no pressure, no market pressure, no governmental pressure, no pressure at all on the pharmaceutical companies that sell insulin to lower their prices to the same extent that there is in Canada.
All right, let me ask the doctors another question. It is estimated that 1 out of 4 Americans cannot afford the prescription drugs their doctors prescribe. What does this mean for the health of the American people? If I'm sick and I go to a doctor and the doctor writes a script for me and I can't fill it, what impact does that have on health in the United States?
I think it has a critically important impact. There are numerous studies showing that the high price of drugs can lead to non-adherence, which is when patients don't fill their prescription or they extend their prescription or use less of the medicine in ways that ultimately are harmful to them. And some studies led by people in our group here at the Division of Pharmacoepidemiology show that when people are prescribed higher cost medicines instead of equally effective lower cost medicines, that can lead to worse patient outcomes. So it is truly something that is problematic for patients and something that we can fix.
Let me ask you this, and I think, Dr. Persaud, you may have done a study on this. Tell me what I'm missing here, but if I cannot afford my medicine and I get sicker than I should be, and maybe I end up in the emergency room, maybe I end up in the hospital, is it possible, in fact, that we end up spending more on healthcare because people simply cannot afford the medicine that they need?
Yes, Senator, that's exactly what we found in our study. When we provided medicines to people who could not afford them, we realized savings of more than $1,000 per year per patient. And that was due to avoided hospitalizations, avoided emergency room visits. We're talking about life-saving medicines that we know work, treatments for high blood pressure and diabetes. So when people are able to take their medications, they are healthier. We've also found that people find it easier to make ends meet to afford their rent and food. And these are things, healthy housing, healthy foods that people need to be healthy as well.
So what you are saying is that the high cost of prescription drugs result in people getting sicker than they should, and in fact, ending up costing healthcare systems more money than we should be expending.
Yes, you're paying at least twice. Once the higher price for medicines, and second when people land in the hospital with a heart attack or a stroke.
Which could have been prevented.
Absolutely preventable.
Okay. Senator Collins.
Thank you, Mr. Chairman. Before I begin my questions, I would ask unanimous consent that a statement from Senator Burr be submitted for the record.
Without objection.
Thank you. Mr. Brill, you mentioned the role of patent thickets in blocking access to more affordable biosimilars. You also talked about the fact that biologics are very expensive and are consuming an increasing amount of the cost of prescription drugs in this country. Even though there are several biosimilars for the best-selling drug in the world, Humira, and they've been on the market in the European Union since 2018, American patients must wait another 2 years for them to be available here due to the manufacturer's aggressive patent thickened strategy of overlapping and late filed patents. Another method of fending off biosimilar competition is called a drip feed strategy, where knowledge broadly disclosed in early patent applications is defined much more narrowly and specifically in subsequent patent applications. And AbbVie is using this strategy for a cancer drug that it has. How should Congress ensure that we are recognizing innovative science versus rewarding an innovative legal strategy that is simply designed to block more affordable competitors by gaming the patent system?
Thank you, Senator, for your question. The issue of patent thickets and related patenting strategies employed by some innovator companies is, I think, should be very concerning to policymakers. I think we're in the early innings of what will become an evolving set of tools that many innovator drug companies may engage with to protect their assets. And this runs completely counter to the objectives of competition for biosimilars or for other innovative products. We have these pathways through the FDA to create and foster generic competition, biosimilar competition, and the patent system is getting in the way. I know that you have introduced in the past legislation with Senator Kaine, Senator Cornyn, and Senator Blumenthal also have legislation focused on addressing these issues, finding ways to protect core patents and appropriate patents, but to block or prevent the ability of innovators to stack patents on top of each other and create undue, unnecessary, excessive monopoly powers for their products.
Thank you. I think this is an area that cries out for reform. Dr. Kesselheim, the Veterans Administration has some authority to negotiate favorable pricing and deeper discounts. But we also hear complaints that they have a national formulary, and we get complaints in my state offices from veterans who need drugs that are not available on that formulary. So how do we come up, if we move to broader use of negotiation by the federal government, while still ensuring that there is patient choice of medications, that their physicians can still prescribe and they can get reimbursed under the terms of their insurance for the medications that are best suited for them?
Thank you, Senator Collins. It's a great question and an important one. And I think that the principles that I was outlining are really a principle of evaluating the effectiveness of drugs and negotiating on that basis, and not necessarily about restricting access to the products, but providing coverage to products that are extremely effective, and not providing the same level of coverage to products that don't offer additional benefits. And so that's the model that some states have used, like New York.